Good afternoon, everyone. My name is Jeff Norris. As the board president, it is my pleasure to welcome you all to the 8th annual meeting of Community Health Options, a member-led and member-directed health insurance company. Before we begin, we have a few administrative reminders. First, please note that this meeting will be recorded. If we become disconnected or have other technical difficulties, please visit our website at healthoptions.org, where an announcement will include a link to rejoin the meeting. During the meeting, those of you who are joining us using the Zoom app on your computer or phone will have the opportunity to ask any question you may have via the Q&A feature at the bottom of your screen. We encourage you to submit your questions at any time, and I will read them after the presenters have completed their remarks. So we have a full agenda, and let's get started. Community Health Options is distinguished by our approach of partnering with our members, providers, and businesses to lower the total burden of healthcare costs while improving healthcare outcomes. This partnership model is rooted in our underlying nonprofit status and, most importantly, our member-led structure. To ensure that Health Options maintains a majority of board directors who are elected by the members, we conducted our board election process beginning this past spring. At that time, the structure and approach was determined in order to allow for maximal participation by all members of majority age. We first had an open call for candidates to run in the election, culminating in the strong list of impressive candidates that have appeared on ballots issued to our members in early October. They were delivered by physical or email addresses to those members. The collection and counting of the ballots was administered by our contractor, Election Services of Melville, New York. So now to share this year's election results, I would like to introduce Judy Ann Smith, Secretary of the Board of Directors. Judy Ann.
Thanks, Jeff. Can you hear me?
You can. Yep.
Great. Okay. So as Jeff mentioned, I am the Secretary of the Board of Directors. The Governance Committee is responsible for designing an appropriate nomination and election process for the board. The process includes nominating a slate of qualified candidates to be considered as potential board directors through a contested election by the members and in compliance with both state and federal laws and regulations. The majority of board directors must be member elected, and because elections must be contested, only 6 of the candidates could prevail. And it's my pleasure to announce that 2 current board directors have been reelected. Sharon Reichus from Somerville has several decades of private sector consulting and government experience centered on strategic planning and policy analysis. She is chairman of the trustees of Unity College, and Sharon serves on our board's audit and strategic planning committees. Mitchell Stein of Brunswick spent many years with the Mercer consulting firm working on the National Survey of Employer-Sponsored Health Plans. During the rollout of the ACA, he was the policy director for Consumers for Affordable Healthcare, or CAKE. Mitchell serves on the board's strategic planning and member experience committees. We appreciate both of their contributions and their continued work on the board. In addition to our 2 returning board directors, the following 4 individuals, 2 of whom are members and 2 of whom are non-members, also have been elected to 3-year terms on the Community Health Options Board of Directors. They are Paul D. Andrews of Falmouth. He's a Maine native and a UMO graduate who spent many years working for then Congresswoman Olympia Snowe and has years of insurance experience working in auto, property, life, and annuity products. Welcome, Paul. Leslie Clark lives in Portland and is an executive director of the Portland Recovery Community Center, a nonprofit organization providing peer support, education, advocacy, and resources for people affected by substance use disorder and other addictions. Welcome, Leslie. Jared Cronkite grew up in Aroostook County on a family farm and currently lives in Rockport. He is a certified financial planner who manages all aspects of his own financial planning business. Welcome, Jared. And Corey McKenna from South Portland earned his Juris Doctorate from University of Maine School of Law. He practices law primarily as a court-appointed attorney, operates his own law office, and works with several local nonprofit community organizations. Welcome, Corey. On behalf of the entire organization, I thank all the candidates for their willingness to serve, and I congratulate our 6 board directors being appointed for terms beginning in January. And I guess that concludes the secretary's report. I'll hand it back to you, Jeff.
Thank you, Judy Ann. We really do appreciate the time and commitment of all the new and returning board members who serve as volunteers and contribute much to the organization. At this time, I am pleased to introduce Kevin Lewis, the President and Chief Executive Officer of Community Health Options, who will recap a few of our organization's highlights from 2021. Kevin?
Yeah, thank you, Jeff, and good evening all. And first of all, I want to congratulate our board directors, new and returning. Health Options is strengthened by our committed, savvy, and mission-oriented board. And it's really no surprise that here in Maine, we find such high caliber people who step forward. We thank you for answering the call, and we thank our members for participating in the election. 2021 has been another incredible year of achievements here at Community Health Options and in service to you, our membership. And our accomplishments are achieved because they are powered by the purpose of our mission. At our core, we position people over profits. We partner to get big things done for our members, all with a focus on lowering total healthcare costs, improving health outcomes, and improving the experience along the way. Before I mention some of these achievements, it's important to note that this year we proudly recognize our 10-year anniversary since our incorporation. And we wouldn't be here today but for the incredible hard work of our staff. So in a review of some highlights, I'm pleased to spotlight our launch of our self-insured product, Pioneer ASO, which brings our excellence in service, our sophistication in analytics and reporting, and transparent business model to the benefit of our state's employers and their employees in this self-insured product. Evidence of the results in lowering total healthcare costs is found in part in our delivery of significant medical loss ratio rebates, with average rebates to individuals of greater than $1,000 and average rebates to our large group around $9,600. We are also pleased to lean in and support various public health and addiction treatment and recovery supports with grants to 14 fellow Maine nonprofits. Another way we're providing support to improve access to care while lowering the total cost is through our provision of a $0 cost share for urgent care through our telehealth benefit supported by Amwell. This aims to help all of our members, whether they are juggling work demands, kids' needs, in need of quick assistance in the middle of the night, or a far drive from the closest bricks and mortar urgent care, or perhaps all of the above. And the way in which we do our work has resulted in 5 successive listings as among Maine's best places to work, gaining the award each time we have applied. Another powerful validation of our efforts has been the achievement of a 4-star rating by the National Council for Quality Accreditation, NCQA. Beyond the rating itself, this really reflects on our dogged pursuit of closing gaps in care and supporting our members across access timely care that thwarts downstream calamity and ultimately saves lives. This dedication to supporting our members is captured in these 2 top achievements you see here, showing that high quality can and should reduce the total cost of care. Through our care management work, we have reduced total cost of care by $12 million, either helping with reduce out-of-pocket expense and or lowering premium. Some of this was the result of our avid care management nurses who cut our readmissions down by half and consistently are below industry benchmark. We are pleased to count nearly 1,300 small businesses as our clients and work hard to retain their trust with a stellar retention rate, just as we work to maintain longstanding membership across all lines of business. This commitment to our mission also translated to solid financial marks for the company. Our last fiscal year end brought our capital surplus position to $140 million, a doubling since 2017. In closing, I want to extend our appreciation to all of the hardworking staff of community health options, as well as to you, our community partners, our network providers, brokers, assisters, and most of all, you, our members, for it is you who make this all meaningful. And with that, conclude the remarks for 2020 and 2021, and I'm proud to hand it back to you, Jeff, as we introduce, bring Maggie Kelly up to introduce our speakers.
Thanks, Kevin. Could I hit you with a question first?
Please do.
Could you describe how the organization is supporting its staff during the ongoing pandemic?
Great question. And I think that is one of the reasons why we have been named one of the best places to work. As many know, we quickly pivoted back in 2020 to move people out to remote work. This was actually achieved in large part so quickly because of the early efforts on the part of the claims team and the service team to really be able to extend our reach throughout the state and allow for people, whether up in Fort Kent area or down south, to participate in the work. Not knowing for sure how long this would take place, we had to continue to evolve with the tech needs, with the technology needs, as well as with the pure HR needs. So it's been an evolving process, and we continue to learn and grow and try and really listen to what the needs are of our own people as we try and make sure that all of them are fulfilled in the work that they're doing in support of our members. So I can't say we have it perfect. We're humbled to try and get it better each and every day. And I'm just ever so grateful for, again, the way that our people, our team has continued to dig in and make it work in a very challenging time.
Great, thank you. Thanks so much for your remarks, Kevin. And on behalf of the board, I'd certainly like to recognize the excellent work that you and the entire Health Options team is doing. So next up, we're pleased to have our guest speakers who are joining us to discuss the important and timely topic of, quote, the other epidemic, unquote, which refers to the escalating number of people experiencing substance use disorders in the state and in the country. While you hear these remarks, I want to reiterate that you're encouraged to ask any questions you might have via the Q&A comment. So to introduce our speakers, I now welcome Maggie Kelly, Health Options Senior Vice President and Chief Clinical Officer. Maggie?
Thank you, Jeff, and good afternoon, everyone. Substance use disorders. Maine has lost too many of our people to substance use disorders. The Margaret Chase Smith Policy Center at the University of Maine, Orono reports 247 fatal overdoses between January and May of 2021. This number is 20% higher than the same period in 2020. The COVID-19 impact on behavioral health has only intensified the need of all of us to pull together to end this crisis. Governor Janet Mills' administration has taken a multi-pronged response to the escalating substance use in the state, to include ramping up her 2019 Maine Opioid Response Strategic Action Plan to reduce the negative health and economic impacts of substance use disorder for Mainers and their communities. Community health options. As the state's only nonprofit member-led health insurance organization, Community Health Options wants to align our behavioral health efforts and resources with the important work that is happening throughout the state. We support a community-based approach that values integrated healthcare for the whole person that starts with prevention through screening and early intervention. Our team recognizes that primary care providers are often the first responders for behavioral health, and they are responsible for providing integrated care for all related mind, body, heart conditions throughout the lifespan. We expect and encourage evidence-based services such as medication-assisted treatment for people with opioid and alcohol use disorders in line with Maine-based initiatives and the Maine Opioid Response Plan. Our members rely on us to have a collaborative relationship with local providers to ensure coordinated support and critical continuity of care. Our behavioral health medical director recently described the high energy and talented trio at the core of our multidisciplinary care team, who act as a singular powerful force, proactively searching out and connecting members to needed services, removing barriers, and collaborating with providers and external care managers to ensure care continuity with a whatever it takes mindset. This is exemplified in a thank you note we recently received from a greatly appreciative mom. She said, "Thank you again for all your help with this. I am so sorry I was short with you. It's been a long 2 weeks and it was scaring us how bad it was getting. I can't thank you for all of your help and support and working late to get this situated for our child. Please reach out to all who made the decision to approve this. Let them know how truly grateful our family is for all the help and support you have all given our family. We can't thank you and all your colleagues enough." We have a very dedicated clinical team who really care about our members. And while our direct work with members is impactful and rewarding, we also recognize the importance of supporting our community partners. Health Options recently awarded $50,000 in grant funding to 6 Maine nonprofit agencies. These agencies are helping people who are living with or at risk of substance use disorders, supporting people with substance use recovery and continuity of care, and reducing negative substance-related health impacts in the state. One of our speakers, Leslie Clark, is the director of Portland Recovery Community Center and one of our grant recipients. Both of our speakers, Tim Rourke and Leslie Clark, have devoted much of their careers to improving substance use disorder treatment. They have seen firsthand how the financial and societal instability caused by the pandemic has exposed millions of Americans to substance use disorder risk, causing the other epidemic. Tim and Leslie share a passion for building patient and provider connections to remove substance use disorder stigma, break down barriers, build trust, and greatly improve care and treatment and recovery journeys. Both will provide their personal experiences of working in the local, regional, and national substance use disorder support community before and during the pandemic. Tim Rourke is our first speaker. Tim is a senior director at Third Horizon Strategies, a healthcare advisory firm based in Chicago. He previously served as a director at the New Hampshire Charitable Foundation, where he provided leadership on the foundation's largest philanthropic initiative and guided strategic investments in early childhood education and care, family and youth support, substance use disorder services, and educational pathways to build the future of New Hampshire's workforce. Tim also served 8 years as the chair of the New Hampshire Governor's Commission on Substance Use, advising state and nationally elected officials on issues of behavioral health and health policy, and leveraging public investment to increase access to prevention, treatment, and recovery services. Tim's current work is focused in part on raising awareness that, as a nation, we need to get our arms around the interconnectedness of health outcomes and social determinants of health. In behavioral health, this means making sure that communities have capacity to provide recovery supportive housing, career and educational pathway programs, and similar efforts to assist those living into their recovery with the community supports, tools, and resources needed. Our second speaker is Leslie Clark. As executive director of the Portland Recovery Community Center, and in her earlier roles, Leslie has worked with underserved populations, especially those who have experienced trauma, discrimination, and addiction. Her past work includes serving as founder and CEO of Greater Portland Health, president and CEO of Community Counseling Center, and executive director of Texas Association of Licensed Children's Services. The Recovery Center's vision is to see that every person affected by addiction in Maine will have direct access to a local recovery community center and support through all stages of the recovery journey. The center believes that better educating healthcare providers about substance use disorder and the needs of people in recovery can ensure more compassionate and dignified care. Their grant project will dedicate resources to working directly with individuals in recovery so that they can effectively advocate for their own needs in healthcare settings. The project will also develop a patient's bill of rights for individuals in recovery to use when they are seeking medical care. And now I turn to our first speaker, Tim Rourke. Tim?
Thank you, Maggie, very much for that wonderful introduction. And thank you to everyone at Community Health Options for inviting me to come and speak tonight. It is an honor to be here. And to all of you, thank you for giving of your time this evening to be part of this important conversation, and greetings from your neighbor to the west here in New Hampshire, where I am based. I'd like to start off by talking a little bit about where we are in our nation's opioid epidemic. And unfortunately, that's not a good place if you've been looking at the news over the last couple of days, but it makes tonight's conversation all the more critical as we think about how to improve the lives of those who struggle with the disease of addiction. Yesterday, the Centers for Disease Control released a report that updated the death rate due to overdoses in the United States between April of 2020 and April of this year to over 100,000 people. That is the first time in the country's history that our overdose deaths have reached over 100,000. And that actually doesn't begin to speak to the full loss of life that can be attributed to the misuse of alcohol and other drugs, because that is just overdoses due to opioids. And yet we know drugs like alcohol actually lead to more deaths than all illicit drug use combined. So unfortunately, we are truly in the midst of this other epidemic happening behind the scenes of our current COVID crisis. And I wish that we could say that we could look at those higher overdose rates and attribute them to the pandemic. And in reality, we can't. What we are seeing right now is the manifestation, the outcomes of an epidemic that has been raging through this country, not just for the last 10 or 15 years that we've been talking about opioids, but for 20, 30 years, where we have seen the silence and the stigma drive the disease of addiction underground. In New Hampshire, where I live, again, right across the border from all of you, we have actually had the highest rates of substance use disorders per capita of almost any state in the United States since the late 80s. While our opioid epidemic is front and center, even in those who seek help for care at the height of our opioid epidemic, we traditionally see that the vast majority of them who come in seeking treatment and recovery supports aren't just misusing or addicted to opioids or have an opioid use disorder, they are polyusing. So for my work, when we talk about our nation's substance use epidemic, we need to talk about it fully, not just how opioids have provided fuel to the fire of an addiction epidemic that has existed long, long before communities in general started to talk about it. We do, however, need to recognize that even though what we're seeing right now is the outcome of 30 years of high rates of addiction in the US with very limited capacity to treat them, the pandemic of COVID-19 could not have come at a worse time. It has exacerbated isolation. It has driven trauma among those who were already struggling with substance use, among those in communities who are at risk for struggling with substance use. Addiction is seen very often as a disease of belonging, and yet for almost a year, many of us have been alone in rooms, distant from physical touch and physical connection with those communities that we need for our own mental health and well-being. So the data from the CDC yesterday about over 100,000 deaths is only the tip of an iceberg that we as advocates, providers, payers, and community members need to really think about as we move forward in delivering healthcare to our citizenry. So what do we do with that number? Because the reality is it's 100,000 now, and all signs are that that number could grow greater if we don't intervene. We certainly saw in the United States and here in New England, as the pandemic began, we saw decreases in people seeking treatment. The advancement of telehealth allowed some of that to rebound, but we know that there are families and individuals who have been distanced from the healthcare system, distanced from their social networks, and have been further traumatized in such a way that our current rates of substance use in Maine, in New Hampshire, and across the United States are very likely to get worse over the next 3 to 5 years as the pandemic's impact continues to manifest in our communities. So the question becomes, knowing that what we have right now is a challenging epidemic of addiction, and knowing that it is likely to get worse, there is an urgency for all of us to respond. And what are some things that we can be doing about that? And that's what I'd like to talk about at a high level in my brief remarks with you all tonight. I see 4 areas where I think all of us need to be putting more time and attention. The important thing to understand around substance use disorders, for those of you that don't live and work in the behavioral health space, is substance use disorders is a chronic relapsing condition. It is very similar in many ways to other chronic relapsing conditions, diabetes, hypertension, heart disease. It has a lot of parallels in many ways to certain types of cancer, where family history increases risk, where environmental exposures play a factor, and where there is not a one-shot cure, but there are multiple pathways depending on the nature of someone's struggles with substance use that they need to be able to access in order to find the treatment and recovery supports they need, not just in the moment, but over the course of their lives. So it is important that we recognize those things and think not just about how we provide clinical treatment to an individual who presents as in need of treatment, but how do we build a comprehensive continuum of care, from primary prevention services that are targeting young people all the way to the long-term recovery supports. And you're going to hear more about long-term recovery supports from my good colleague, Leslie, in a little bit. But it is important to understand that we need all of that. And in the absence of all of that, we catch people too late. Those 100,000 deaths that the CDC reported yesterday were preventable. Had there been systems in place, had there been communities prepared to hold and support those at the earliest signs of trouble with substance misuse, we may not see those numbers in the way that they are. So building out those kind of comprehensive systems remains critical. But let's get very specific, because one good thing, if there is a silver lining about the opioid epidemic and even about the COVID-19 pandemic, is it has driven growth of services, expansion of supports, and new technologies and strategies to improve outcomes for people who can access them. So we have public health and prevention services that are taking place in schools. We need more of them in communities everywhere that young people are, but some of them already exist. We know that there are good partners in the treatment space, hospitals and FQHCs and others who are partnering much more closely with specialty addiction treatments. And we have the growth of the leadership of those with lived experience who are developing recovery community organizations and the kinds of proactive, pro-social community supports that can ensure when someone gets treatment, their likelihood of long-term success is only increased. So fortunately, we're not starting from scratch, but in this moment, as we see the epidemic going in the wrong direction, there are a few critical things that need to happen that I'd like to highlight for you in my remarks. The first is that we need to get better at screening. Addiction, as I've said, is a preventable disease. It is chronic, and it is progressive if it is not caught. So catching it early is one of the most important strategies. But we often think of the disease of addiction relative to how it shows up in our treatment systems among adults. The reality is that substance use disorders are a children's disease. One of the biggest predictive indicators of substance use later in life is the misuse of recreational substances before the age of 15. So it is critical that in pediatric practices and in adult practices, in emergency room settings, in schools, in social service organizations, we have providers who are trained to see the warning signs of problem substance misuse, to screen for challenges around substance misuse, and then to know how to build out those referral pathways to get people the support they need. Or if it's really early stage, how do we support people making different choices to manage their stress, manage their anxiety, manage some of the factors that go into the decision-making around early onset use. So screening needs to happen. Screening should be taking place for everyone over the age of 12. In the state of New Hampshire, when I was with the Charitable Foundation, we launched a multi-year effort to train pediatricians all across the state of New Hampshire to screen pediatric patients over the age of 12. What we found was not necessarily significant numbers of adolescents who needed treatment, but we found a lot of young people who were exhibiting the early signs that they were at risk of developing a substance use disorder. And then we found pediatricians and their practices who were informed and inspired to do the right kind of coaching, the right kind of support to ensure that those young people didn't go down that path towards their future. We need to see more of that, not just for young people, but for adults as well. We know, in addition to misuse of recreational substances among young people, we know that substance use disorders is very often driven by toxic stress and trauma. And I would posit to all of you that every single one of us has experienced a level of trauma as we have navigated the complexities and the hardships of the last year and a half. Everyone who sees a medical professional should be asked about their substance use, not just illicit drugs, but alcohol as well. And building out that screening more robustly is going to be critical if we want to stem the tide of what is coming in terms of increasing challenges and demand for substance use services. The second thing I think we need to do is we need to build systems that actually help people who are struggling with addiction get the care they need, just like someone who might be struggling with a cancer diagnosis or a type 2 diabetes diagnosis. Substance use disorders are one of the only diseases on the planet that as a society, we look to people to self-diagnose themselves. And then worse off, even if a professional or a loved one is able to say to someone, or the person themselves comes to realize, I have a problem and I need help, we hand them to Google. Or back in the day, we gave them the white pages and we told them, go figure it out. There's no other disease that we do that with. If someone gets a cancer diagnosis, they're usually shuttled to an expert, to someone in the oncology arena who can guide them through the right treatment systems. We need to build those early doorways into care for people who are ready for help. In the state of New Hampshire, we did build something called the Doorway, borrowing from the hub and spoke model in Vermont. And it was an answer to the challenge that we were having in our state, where there were too many people who still didn't think that help was available. And there was too much white noise that they couldn't navigate through to get to the right level of care. We also had a lot of people who were, quite frankly, sitting on waiting lists for treatment they didn't need because they hadn't yet gotten in front of someone who could do the kind of screening I spoke about, who could do the right kind of clinical assessment, specifically diagnose the nature of their substance use disorder, and then hold their hand, navigating them towards the actual care they need, whether it's residential treatment, intensive outpatient, MAT, a combination thereof, or maybe just long-term recovery supports. So building out those systems and understanding how people access care and how can we help people who have this complex chronic illness navigate the systems to get the care they need when they need it and when they're ready for it, I think is a critical space where all of us need to do more work. The last piece that I would like to raise is the ability to create a network for good. As I've said, substance use disorders is a chronic illness. An individual episode of treatment or the exposure to one treatment protocol is simply not enough to sustain people's recovery over a lifetime. We also know, and I quote one of my favorite partners in the recovery community said to me once, all of the treatment in the world is meaningless if I don't have a place to live and a job to pay for that roof that's over my head. So we need to build systems that treat and support and care for the whole person, as they enter treatment, as they navigate recovery. That means we find the right kind of treatment and recovery supports, but it also means they have safe and sober living conditions. It also means that if they've been out of the labor market because of their illness, they have an opportunity to get back in a meaningful, long-term way. All of that requires centralized coordination and support. Whether it's a recovery coach in a treatment center, whether it's connecting them to that recovery community organization that can help them navigate the system and navigate all those resources they need to build back their lives. There's more work we in communities need to do to bring that kind of centralized care to really treat and support the whole person. These 4 things, building out the continuum, making sure that right now we are screening everyone we can for problematic substance use, making sure that if someone is reaching out for help, it is easy to get them to where they need to go. And then as they navigate that care, there's hand-holding throughout to make sure that they're able to return to living fully into their recovery requires everybody. And that is where I think the work of community health options and all of you on this call tonight become so critical. The organizations that were talked about earlier in the community that are providing these services, they need time, talent, and treasure. They need support from their communities. They need the resources to build out what we know works in addiction treatment and long-term recovery supports. Payers like community health options need those providers to partner with them. If community health options has resources to bring to bear to improve the quality of life for their patients and their covered lives, they need providers who are willing to be needed with them to really think about how to foster innovation, foster expanded programming, and take the resources available from an organization like Community Options and leverage it against community goodwill and other resources that the state and local communities have at their disposal. And then we need the community. This disease still spends far too long in the shadows. Stigma has been the biggest driver of our nation's addiction epidemic over the last 30 years. We need communities that will hold up and honor and support those who are living into their recovery with the same kind of rallying community support that we see with cancer patients, that we see with patients of other illnesses, where there are colored ribbons and walks and communities willing to support the existence of those services. That requires everybody to come around the table together. In the absence of that, I lose sleep about where we go next. But it's organizations like Community Options, the providers that you've heard about, the services that are now increasingly available. While things are bad related to substance use disorders in this country, it is also important to remember we know what works. Treatment and recovery supports for people struggling with addiction, when applied at the right time, at the right level, the patient outcomes are as successful, if not more successful, than the treatment of other chronic relapsing conditions like type 2 diabetes or hypertension or heart disease. So this is not an epidemic where we actually don't know our way out. The way out is to build out those communities of recovery supports, build out those systems of care, and then to make sure that patients feel empowered and matched with providers who can bring them into their recovery journey and navigate them through all the way to the end so that they can go back to living robust and healthy lives and continue to be contributing critical members of our communities. It's heavy work, it's complicated work, and it's certainly more complicated now because of what's happening in the pandemic. And yet, our CDC numbers yesterday should be a wake-up call. There is an urgency, and there is an opportunity for all of us to do more and do better. So that is my charge to all of you, to continue to go out there, to continue to elevate the importance of addressing behavioral health. We have an opportunity right now to actually turn this epidemic around. If we don't, our communities will pay for it for a generation. So I encourage all of us to continue to work together to think about how to foster innovation in care and bring evidence-based practice to every individual who needs it, because they deserve it. They deserve it from all of us. They deserve it from their communities, and they deserve it from you. So with that, I'm going to pause, and I'm going to turn it all over to Leslie from the Portland Recovery Community Center. Leslie?
Good evening, and thank you so much, Tim. I was really inspired by your comments and honored to share this keynote with you tonight. And I was thinking as you were speaking that the theme for the National Recovery Month in September was recovery is for everyone, every person, every family, every community. And that really came to mind as you were talking about the systems that we need to build and the hope and the involvement of everyone. I'm so thankful to be here tonight and honored to be here and to be elected to the board of Community Health Options. Thank you so much, Jeff and Kevin and Maggie. In thinking about speaking tonight, I was thinking along with that same theme that today when I introduced myself not just as the executive director of Portland Recovery Community Center, and I'm looking forward to sharing some about the work that we are doing and doing statewide. But today I introduced myself as a person who is in long-term recovery from addiction to alcohol and drugs. And for me, what that meant and what that looked like was a compulsion to use alcohol and drugs despite the negative consequences that no amount of good intention or willpower could override. And today I am blessed to have been in recovery for 32 years and active, almost 32 years, and always an active member of my recovery community since 1989. And yet, as a social worker with a background in community health and community mental health and leadership roles, I always kept that tucked at the door. I stayed anonymous. I was active in my community, but I didn't share with people that I was a person in recovery. And a lot of that was stigma. I heard people make comments, colleagues that I respected and admired about, oh, you know, that person's an alcoholic and you know what they're like, or that person is an addict and I think they're addicted to something. And even in primary care and with all my good medical doctors and relationships over the years, I never shared that I identified as someone with substance use disorder and as a person in recovery. And then the opioid epidemic came along and everything changed. And resources were coming in. I was working in community health and we were seeing how much people wanted to help and people with good intentions, but who didn't really understand what recovery was. Is it the same as Alcoholics Anonymous? What does that mean? What is that about? And I decided it was time to speak up and come out as a person in recovery. I feel like if we're ever going to get out of this crisis of addiction, we have to transform in the way Tim just talked about and look at what I think of as a trifecta. So there's the medical component, and every person needs and deserves and so consistent with the mission of Community Health Options has a right to good medical care. And this is a chronic relapsing disease that needs to be treated like any other disease that people have access to. And along with it, just whatever aside from the addiction treatment that people need are just the basic health impacts that also need attention when someone is new and coming into recovery and has had long-term SUD, whether that's issues of malnutrition or dental or liver disease, just so many things that people need help with on the medical, as well as medical care for the addiction itself. And then behavioral health. We know that most of us with substance use disorder have histories of adverse childhood experiences, post-traumatic stress, depression, anxiety, and those behavioral health services are so important and critical. And I think it's a place where we have seen such success of the integration of primary health care and behavioral health care in primary care settings, and especially the FQHCs have really led the way on that. But the piece that I saw that was missing in that triangle is the recovery piece, the peer supports that are the bridge to long-term sustained recovery. And we hear it said so often now, the Johann Hari quote about, the opposite of addiction is not sobriety, it's connection. And long-term recovery supports provide a place and a space for those kind of connections. And that's where recovery community organizations come in. So let me just share a little bit about Portland Recovery Community Center. We are a nonprofit recovery community organization. I will tell you that 5, 6 years, 7 years ago, I didn't even know what that was. And now I am the greatest champion, and I love recovery community organizations. So we were founded in 2012 as a pilot, and then became a nonprofit in 2017. And we do 3 things. Like all recovery community organizations, we provide a place for education and resources to help people connect to all the things they may need, whether that's healthcare, housing, those basics, and to educate about the disease of addiction, substance use disorder. We also, at the PRCC, we provide recovery support services, direct services. We are open 7 days a week. We offer over 50 support groups and activities of all multiple pathways and approaches at no cost, and through wonderful support from certainly in these last years from Governor Mills' office and the state of Maine. To give you some perspective, in 2019, before the pandemic hit, we had over 48,000 visits in our little 3,300 square foot building. And in the last almost 4 years, we have been able to serve as a hub and a model to help other communities in Maine start recovery community organizations as well. There are now 17 recovery community centers throughout the state. And in 2017, 18, there were only 2, the PRCC and the Barn out of Bangor. So we provide recovery support services directly, including recovery coaching and telephone recovery support and support groups, resource connections. And the third piece is advocacy, as we work to build on the recovery movement that is founded all the way back to not just Alcoholics Anonymous, but even before that to Native American healing circles, and builds on the work of William White and more recently John Kelly at the Addiction Research Center. I think it's been brought up, and one of the things I want to talk about, the recovery community organizations offer a place for 2 really important pieces for all humans, and especially for those of us in recovery who have been in isolation, and with the pandemic and the collision of these 2 public health crises, more important than ever, which is a place of belonging and a sense of purpose and a connection that I believe you can only experience with someone else who has walked in the same shoes. It's that Me Too moment. It's the walking in the door and saying, this is what I'm struggling with, and having people around you say, oh yeah, I was where you were a year ago, a day ago, 10 years ago. I know what it's like, and I can help you. We start every conversation with, how is your recovery today? Without looking back a lot, or what happened, or what the drug was that got you here. We really focus on meeting people literally in the moment where they are and building from there. Stigma is the #1 issue. I often am asked, like, what do you think is the biggest thing that needs to be addressed, and I really think that is it. The Recovery Research Institute did a study. Nowhere more does this show up than in healthcare. And they did a study that was in Arizona that showed that almost all participants who had received healthcare, usually at the hospital, usually not at their primary care provider, because of the barriers they felt. Almost all of them reported maltreatment by their provider. And I'm not surprised by that. We did a series of focus groups at Portland Recovery Community Center statewide and involved people all over the state that were on MAT or had been on MAT in the past to talk about their experiences. And one of the places that Stigma showed up most, not only, but most, is in healthcare. So some of the examples that came up were even from people really well-intentioned, but somebody who had gone into an emergency room with an infected insect bite that had swollen up, and described how because it was in their chart, in their record, that they had substance use disorder in their history, all the provider wanted to focus on was the substance use disorder. And the person was like, I'm in recovery. I need help with this bite that is on my face. So sometimes it shows up even in good intentions, but it also shows up. A story 2 years ago, someone shared with me was being at a rural hospital where in the emergency room in the middle of the night with chest pain, and because they were known in that ER, was unable to get an exam, was told, we're not giving you drugs tonight, you might as well leave, you are not getting any drugs. And they left and went to a hospital in the city, and that same night found themselves having emergency heart surgery. The stories go on and on about drug-seeking, quote unquote, behavior that prevents people from getting the attention that they need to get well. Last night, I heard a story as recently last night from a young woman who's in one of our moms group, who said that her newborn, relatively newborn, young baby, had been to the emergency room, and she asked for a copy of the record. And quote, the record that she got said that her child was, quote, the product of a pregnancy complicated by maternal history of substance abuse with resultant history of multiple ER visits. She was very upset. She has not used any drugs or alcohol for over 3 years and for a full 2 years before she ever got pregnant. Her baby had a virus. Her baby had a cough and congestion and fever that most likely had nothing to do with her history, and also being written in her chart that her baby's issue was resultant of a history of her, quote, substance abuse, unquote. And I think most people know we really are trying to work on language and help people not use some of those words or categorize or label in a way that prevents ultimately people from wanting to seek care or being willing to seek care. So we're very grateful that Community Health Options has funded this project where we are working to help people in recovery develop not only a patient bill of rights, but some pocket wallet cards that they can use to give their providers, talk to their providers, educate their providers, and help reduce the stigma that people are experiencing and change the system for the better. I want to leave with a story of hope, and I feel like I have the best job in the world. Despite the very sobering and tragic and saddening numbers and increasing numbers that we have seen of overdose, I get to see and want to share and build on, add to exactly what Tim said earlier. There is so much hope. It is so possible to heal from substance use disorder. And I get to see that every single day of hundreds of people and more young people who are recovering from this. And the amount of resources that are supporting building out these new centers throughout the state so that people have a place to go, have a place to connect, have a place to learn new ways, meet other people, have positive experiences, and connect with others is really, really gratifying. So tonight I got, right before this call, I got a text from someone, and as I said, I love being in my job. I see these young people and old people, but young people every day just get better and better and pop in or text me and tell me what's happening with them. And this young woman wrote me today and said it's day 360. And I see how my amazing story is going to be and can become somebody else's survival guide. Today, I'm going to do the next right thing, and then I'm just going to keep doing it and never give up. And so I thank you for being here tonight and hearing a little bit of my story and the work of the recovery movement here in Maine and recovery community organizations in Maine. And I encourage you to reach out anytime for more information, to connect to a center in your area. I really am grateful for the work of Community Health Options and to be a part of it. And feel free to call me anytime if you or someone in your family needs help.
Thank you, Leslie and Tim. Both timely and inspiring stories and presentations. Are you prepared to answer a few questions before we leave?
Absolutely.
Absolutely.
Yeah.
We said it together.
No, that'd be great. Just leave your mics on and we'll just go back and forth. Some of them are, you guys can kind of tag team it however you want to do it. And there were some questions regarding the stigma issue, which you both emphasized. And, typically we see, inspiring stories of athletes and celebrities and other role models who, sort of, address their issue, going all the way back to sort of the, Betty Ford model. And those are great, but I'm wondering if there's anything new under the sun and what you have seen as a positive change, in fighting the stigma. Is there any hope there?
Jim, do you want to go first? Do you want me to?
Sure. Well, I'll start, although I'm going to put Leslie perhaps more on the spot, because I think that it is one of the bright spots has been the growth of the recovery ecosystem that Leslie just spoke so eloquently about and represents. I am always first to point out, I am not a person in long-term recovery. I see my career as an effort to be a deep ally to the recovery community. But I have seen both in Maine and here in New Hampshire where I live, we have had this growth of recovery community organizations, of people with lived experience who are speaking out and sharing their stories. I also think the voices of families who have lost loved ones, it has just elevated the dialogue. And I think it has created a space where, in particular opportunities for our recovery community and our medical community to come together, to educate one another. Some of our recovery advocates in New Hampshire are doing communications trainings and making them available to the first responders and medical staff in their communities so that they're thinking about language, which, as Leslie referenced, is so important. So I see the ability to support the growth of the recovery community and the visibility of the recovery community is probably one of the biggest weapons we have against stigma.
Great. Leslie, you have anything to add to
Thank
that?
you. I agree so much with what Tim said. And I think it's so much better, and the progress in the last few years is tremendous compared to time before that. And I think we have so much further to go. Yeah, I think a lot of it does have to do with education. And as Tim talked about at the beginning of helping people understand the disease model, the complex brain disease that this is one of the key pieces to reducing stigma. You know, we talk about in recovery how so much of what people know about addiction and have experienced in watching a loved one or in their own, I mean, it's not pretty. It's not like we haven't created through our disease a lot of behavior that becomes very challenging for people to deal with. That's a reality. And so helping people really understand what that's about and differentiating between it being a moral issue and an actual medical health issue, I think is the biggest part of what we still need to do work on, even within and especially within the healthcare community, which you would think that wouldn't be true, but I know that it is. And so I think we need to do more education and then more sharing of our stories, and having people be willing to be about to say, this is me, because otherwise nobody really knows what long-term sustained recovery looks like. They know what the early messy part looks like. And I think that goes a long way with reducing stigma.
Yeah, thanks. Tim, in your experience, what are some of the most successful, community-based substance use disorder response programs, in terms of both being cost effective and or being scalable?
Yeah. So, I think there are two that come to mind, and it speaks, I spoke to one of them a little bit, but around, the New Hampshire Doorway program, this idea of one of the biggest challenges that we've had in addiction is that when the moment strikes, when someone has not only perhaps had it identified that they have a substance use disorder, but they themselves understand that they do and feel like they are ready for help. What I have learned from my recovery colleagues is that the window of time for them to execute on that desire for help is often very narrow. And too often we've left it to individuals or their families to sort of figure out what to do. So that's where things like a hub and spoke model, like the doorways, which I spoke about in New Hampshire. So in New Hampshire, it's operated by all of the hospitals. There's our state's 211 system is keyed into it, but within an hour's drive of wherever you live in New Hampshire, there is an organization. It's usually, again, parked at a hospital, where someone who is ready for help with substance use can walk in the door and very rapidly get a clinical assessment to determine their level of need, and then some care coordination to get them to the actual treatment they need. Efforts to shorten that window of time are critical and cost effective, because if that window of time drags out, in New Hampshire, one of the reasons that we had a substance use epidemic in the way that we did when the opioid epidemic hit was that it took far too long for people between the time they raised their hand saying, I need help, until we got them in front of the actual help they needed. So things like doorways or building out those referral hubs are critical. In Manchester, New Hampshire, people may be aware, there was an initiative called Safe Stations, where 24 hours a day, anyone could walk into a fire station, and the EMTs there were trained in how to at least do a quick screen and a warm handoff, make sure the person was safe. we found those to be really effective, because what has happened is people are, when you have that first point of contact and a positive experience in that first point of contact, it allows people to feel more motivated to get into treatment. They get into treatment faster, and we stopped seeing what very often has happened in treatment systems, where people don't complete the treatment because they get there and they decide it's not for them, or it takes too long to get in, and then the person changes their mind and sort of goes back into their use pattern. So that kind of early intervention, those moments of warm handoffs, I think have been incredibly effective. Also, Maggie pointed it out in her opening remarks, medication-assisted treatment is a game changer for substance use disorders. And it's important to understand that medication-assisted treatment is not only available for opioids. We've had medication-assisted treatment opportunities for alcoholism for many, many years now, as we are a nation where the epidemic is shifting and there's concern about methamphetamine use. There is research underway to see if there are similar medications that can be developed to help reduce symptoms of withdrawal and to help people feel well enough to fully engage in treatment. And I think that's a really critical piece that has been new over the course of the opioid epidemic. And the more we can make medication-assisted treatment available in those clinical interventions, the better outcomes we will see.
Yeah. So here, a question from an attendee. They're asking for some clarification when you talked about referring to a specialist. Did you mean an addiction specialist, such as an addiction psychiatrist or addiction medicine physician, or a waivered provider, or any provider working in the substance use disorder treatment space? What?
Yeah, any, except, but with the caveat, the right one. And again, I think that's where, New Hampshire was often seen during my tenure working to build the state system. We were one of the states with the lowest treatment access in the country. And around 2013, the only other state in the US where you were less likely to get treatment was Texas. And what we found was that the problem was actually twofold. One was we literally did not have enough capacity in our treatment system. But the second challenge we had is we had too many people, as I said, sitting on wait lists because they called every treatment center under the sun to try and get in. And we had people sitting on wait lists for treatment they didn't need. So that referral pathway becomes even more important, that it's not just referring them to anybody, but referring them to the right person based on a clinical assessment and a diagnosis of their exact level of disease, and then matching that with the right service provision out in the community.
Yeah, fair enough. And you had talked about how it's a disease that, we currently require self-diagnosis. Are there actually new and better screening tools that people or families can use these days?
Well, I think the real play is not so much what families can use, but are we making sure that our medical community is trained in the right screening instruments? There are, SBIRT is the protocol, screening, brief intervention, and referral to treatment. There are SBIRT screening instruments that are validated for adults. There are screening instruments that are validated for pediatric populations. I do think that there is an important role on the prevention side for public awareness and communications to, one, destigmatize addiction, full stop. Two, to encourage people to seek help. And then three, to communicate with people, because very often when someone runs into trouble, the people closest to them are the ones who notice first. And so I do think that there is a case to be made as well to make sure that in communities, there is the right kind of public awareness messaging that isn't just targeted at upstream prevention for kids, but that really helps people understand that treatment is possible, that recovery is possible, that there are services available to people who need it. And then what are the first one or two steps that any loved one or community friend could take in order to get someone the care they need?
Yeah. So the SBIRT tool, for example, how widely available is that? Do most providers, a few, all have access to it?
It's a great question. They're both widely available. I think there has been, SBIRT as a protocol was originally validated for adults and was most frequently used in emergency room settings. It has subsequently, over the last few years, become validated for adults in primary care practices, and most recently, and again, this was some work that I was involved in, with pediatrics. I think pediatric practices are the place where there's probably the least implementation of that kind of early screening. But oftentimes evidence-based practice boils down to common sense. And we know that for youth, the average age at which a young person starts using substances of any kind is 11. So logic suggests that any child over the age of 11 or 12 should probably be asked if they're using substances by their pediatrician. And there's some wonderful work, particularly out of Children's Hospital of Boston, around how to implement that really well. That's done by Dr. Sharon Levy, who's one of the architects of adolescent SBIRT in the country.
Yeah. So, you were talking about a statewide program, and Leslie, your story about expanding from 2 to 17 community recovery centers is really amazing. And as we know, New Hampshire, like Maine, they're really, 2 states each, not just one. And I'm curious about, the geography of the issue, and, where telehealth plays a role in terms of access. Is it effective? I mean, obviously it's expanding. Can it be effective in, I'm picturing, Zoom sessions, basically one-on-one or group, et cetera. I mean, what is the nature of telehealth in this field?
Great question. So the recovery community centers that are growing throughout Maine are serving largely rural areas, as well as now Bangor and Portland. So they're in communities in Caribou and Holton and Calais, and out to the west to Bridgeton, along the coastline. I mean, they're really pretty much starting to be all throughout Maine. During the beginning of the COVID, we were able to pivot really quickly into offering Zoom meetings. And while at first people felt like it was very awkward and were really concerned about losing that in-person connection and connecting using video, it actually also had some real silver linings, especially for people in rural areas, because they could connect to groups and can continue to do so. A lot of the groups have continued to stay on either as hybrid or as virtual meetings, and have kept it that way. It allowed and has allowed parents. We've seen a lot of growth in participation from young moms and young dads who couldn't get places as easily before, and can feel like they can participate safely with their kiddos running around and not have to leave the house. So there were some real silver linings. I think it will continue. One of the striking differences I thought I would just mention is there's a growing evidence base for recovery community centers and peer recovery supports. And one of the tools that is used by peer recovery coaches, which there are now over 500 trained peer recovery coaches in Maine, one of the tools that they use and we use is called a BARC, which is a brief addiction recovery. I should know this. Anyway, it's a quick, valid instrument that looks at recovery capital. So it's a very strength based. So once the SBIRT and once people get connected and once people then get to recovery, what we really want to do and are able to see is that they're coming from a strength base, and they can sit with a coach and say, okay, let's do this quick BARC, and which I'll get the name of later. And where do you have strong capital? Oh, you have a family that really supports you, for example. So you've got some good capital to work with. Where are you low in capital? And how do we build that capital? When we look at the BARCs for people who are coming in very early in recovery, and then we look over as months go by, we can see that throughout the state of Maine, as a result of these services, people are getting better. It's really exciting. We can measure it, we can see it. The other thing that strikes me, though, is that when I look at the BARC scores, when you get to those rural areas, the scores at the baseline walk in the door, first time ever taking the BARC scores are much lower. I mean, significantly lower than the people who are walking in the door to the PRCC in Portland or to the Bangor area. And I don't know exactly what that means yet. And it's not that they aren't also low for people brand new. But they're lower in those rural areas. So those populations are, I think, and we speculated that it's, there just aren't as many resources. There aren't as many resources, and you can see it. You can see that people don't have all that they need to build their recovery. You can also see they're getting better. And I'll say this last thing on the BARC score. I think it's a score of 47 or 48. That when people, once they reach that score, the odds of them having successful recovery for a year or longer, like that's the score. So we are seeing that all over Maine, people are getting to that score of 48 and above when they're engaging and getting involved with the coaching. So it's very positive and a positive story. If we can just get people connected to everything they need and then give them the ongoing support, they've got a really, really good chance.
Yeah, and a question here is, what is the most important thing that would help build sustainability of these recovery community centers? Is it finances? Is it, legislation?
Well, we've seen some legislation, and we've seen so much support and funding come in through the governor's initiatives around the epidemic and all the good work that is being done. But yes, absolutely, more resources, more funding. The population of people in recovery is growing, and so we need more staffing, more people. So more funding and continued training. And the way it works in a peer-based model is as people come in and get well, and then they get trained as coaches, and then they help others. So all of those kinds of building the workforce, building the certification that we're doing for coaches, resources.
Here's a good question. Someone asked, what's the difference between seeking professional addiction treatment and only attending self-help group meetings? And, where does your organization fit in that spectrum?
Is that, to me, the difference between?
Well, it can be either, just clarifying.
Yeah, I think, one of the ways I look at it is it's not an either or. So I'll talk about sometimes or think about, I'm a cancer survivor, right? So I had cancer 14 years ago, and I had a whole team. So, I had a surgeon, my primary care doctor was involved, and I also went to the Cancer Community Center, and I sat with a group of women with the same cancer and found out, how did you handle that? And how did you tell your job? And how did you explain it to your kids? And, what kind of lotion worked on radiation burns? So it's I look at it as no different than that, really. You need your medical care, you need medical care. And there's this particular way of people who've been there helping other people who've been there that is also hugely helpful. There are people who only go to self-help to recovery groups and do really well. There are people, we've all got like an Uncle George who quit drinking in 1986 and has never touched it since, and he never went to any of those meetings. I think it's a very individual thing, but to me, it's back to that trifecta, is if you can have all three.
Yeah. So here's one that came in that, Tim, you might take, because you were mentioning screening and the importance of, catching this early. The question is, how can parents participate in their adolescent child's treatment for substance use disorder? And what does support actually look like in these cases?
Yeah, what a great question. So obviously, most adolescent clinicians will tell you that when an adolescent enters treatment for substance use, there is automatically a desire to engage the family. It gets a little complicated with adolescents, and we've experienced this in growing adolescent treatment in New Hampshire, in that minors 12 and over can access medical care without parental consent. And so there is sometimes a window of time where a young person might be identified as in need of support, and perhaps the family isn't aware. And so in those instances, most good clinicians for adolescents will work with the young person, or if they're identified by maybe a student assistance provider in a school setting, will work to encourage the young person to be honest and transparent and engaging with their families. Oftentimes, certainly, because we know that addiction runs in families, that if there has to be some effort to explore and make sure that there aren't sort of challenges in the family dynamic where it might be unsafe to disclose that information. But clinicians would often reflect to me in the work that we were doing that their goal is to engage families in that process, while certainly making sure that the adolescent themselves feels comfortable enough and well supported enough to do that work. I would also say, addiction is a family disease, whether the individual struggling with it is a minor or your brother or your father or a grown adult. And I think that when anybody enters into support, treatment and recovery supports, family can play an incredibly vital role in supporting them getting through that effort. And very often, particularly when people's substance use disorders has perhaps brought them farther away from their family, reconnecting with family, again, if it's healthy and appropriate, is sort of a necessary part of that. And recovery centers like Leslie's will not only do support work for individuals who themselves are in recovery, but will run family groups and try and support family members as well. And I think those are spaces where we also need to make sure that it's not just the individual, but if they've got loved ones around them who are supporting them, that those loved ones are also getting the support that they need.
Good, thank you. Question came in right here at the end, and we're starting to get to the point where we have to wrap things up, but I'll just put it out there because it's a very good question. They ask, what is the connection between psychiatric disorders and substance abuse in adolescents and adults? So obviously we could run a whole new meeting just on that. But, how frequently are there, an overlap in the diagnoses between the two?
Yeah, so it's generally understood that about 80% of individuals with one of those have the other. So co-occurring disorders, right? Mm-hmm. Which came first is oftentimes a complicated question. Was the substance use disorder developed in part because the person had an undiagnosed mental illness and was self-medicating? Was there some underlying trauma where the substances were used to sort of mask it? There are substances, methamphetamine abuse in particular, because of the impact of that particular drug on the brain, can actually exacerbate and develop symptoms of depression and some of those kinds of mm-hmm. issues. So which came first can be an open question patient to patient, but they actually co-occur very frequently. And I do think that is another place where systems need to strengthen and get better. It wasn't too long ago in the state of New Hampshire that the way the system was set up is there were two different systems. So if you had a co-occurring disorder, you had to go to a mental health center for treatment, but they couldn't treat you for your substance use disorder. And then the substance use disorder provider wasn't given the regulatory ability to treat mental illness. So that's a space as well where there does need to be work, because it is very common to see both exhibit at the same time. And what we want to do in those instances is, again, make sure that with as few travels through doorways as possible to get the right help, people are able to get care that addresses all of their needs, not just the substance use, but any mental illness that might be underlying it.
Leslie, do you have anything to add about that topic?
I would just say ditto to what Tim said on all of that. Thank you. Yeah, often go together and need to be looked at holistically and comprehensively.
Mm-hmm. Well, the two of you went into a lot of topics, and I guess we'll leave it with the you know, the hope that you expressed. And it is great to see the work that you're doing, and that, you know, you're being supported by your communities. There's more we can obviously do, but just knowing you guys are out there gives us all hope. So I'd like to go ahead and wrap up here. Very, very fortunate to have both Tim and Leslie with us here tonight. And I'd like to let everyone know that they did not ask for anything in return, but as a gesture of gratitude, we've contributed on Tim's behalf to Hope on Haven Hill in Somersworth, New Hampshire. And Hope on Haven Hill provides a safe, nurturing home for pregnant women with substance use disorder, along with their children. And on Leslie's behalf, we donated to the Portland Recovery Community Center as well. So again, we're very thankful to have them here. So with that, we'll conclude our annual meeting, and we thank all of you for attending this evening. We really appreciate and care about our members and partners. So we hope you all stay safe and be well and have a good night.